Hey everyone, let's talk about hepatocellular carcinoma. So, globally, this is known as hepatoma, which is an error, of course. It is a carcinoma and it accounts for approximately 5% of all cancer, but its incidence varies widely in different parts of the world. Okay, so more than 85% of cases occurring in countries with high rates of chronic HBV infection, which is a very important risk factor. The incidence of HCC is highest in Asia and sub-Saharan Africa, areas in which HBV is transmitted vertically. And as already discussed when we were discussing hepatitis, the carrier stage starts in the infancy. Now, moreover, many of these populations are exposed to aflatoxin, which, when combined with HPV infection, increases the risk of HCC dramatically. The peak age of incidence is between 20 to 40 years of age, and in almost 50% of the cases, the tumor appears in absence of cirrhosis. Okay, so it is not necessary that cirrhosis will be present in all cases of hepatocellular carcinoma. This was about Asian and sub-Saharan countries. If we talk about Western countries, therein the incidence has increased due to prevalence of hepatitis C. Okay, because as the number of new hepatitis C cases tripled in United States, but its incidence is still 8-fold to 30-fold lower than in countries with endemic HBV. So there is a pronounced male predominance throughout the world, about 3:1 in low incidence area and as high as 8:1 in high incidence areas. Okay, so this was about the epidemiology, nothing much important, that just that males are more commonly affected and the risk factors are there, which we are gonna discuss in a bit while. So, if we talk about the pathogenesis, chronic liver disease are the most common setting for emergence of hepatocellular carcinoma. While usually identified in a background of cirrhosis, cirrhosis is not required for hepatocellular carcinogenesis. Okay, rather progression to cirrhosis and liver carcinogenesis are driven by chronic liver injury and they take place parallelly. Okay, so, viruses and other inducers of chronic hepatocyte injury and inflammations, they are not themselves oncogenic. It is believed that chronic inflammation with its attendant growth factor and cytokines, they promote the proliferation of normal cell and predisposed to acquisition of mutations. So the most important underlying factors in hepatocarcinogenesis, they are viral infections like HBV and HCV and toxic injuries by aflatoxin or alcohol and increasing non-alcoholic fatty liver disease. Thus, where HBV and HCV are endemic, there is a high incidence of HCC, obviously. Now, co-infection further increases the risk. What is this aflatoxin? It is a mycotoxin produced by Aspergillus species that contaminate the staple food crops in Africa and Asia. Now, these aflatoxin metabolites are present in the urine of the individuals who consume these foods and are aflatoxin albumin adducts in the serum. As discussed earlier, aflatoxin synergizes with HPV to increase the risk further. Same thing they are saying. So, other than this, other risk factors are also there, other than viral infections and toxins. We have alcohol consumption, which again synergizes with the hepatitis virus, and also possibly cigarette smoking, inherited disorders, particularly hereditary hemochromatosis and alpha-1 antitrypsin deficiency, and to a lesser degree Wilson's disease also. Now, metabolic syndrome and its attendant obesity, diabetes, and non-alcoholic fatty liver disease, they all increase the risk. So, in short, what all the risk factors? Most important are the viral infections, hepatitis B and C. Other than this, toxic injuries by aflatoxin, alcohol, and non-alcoholic fatty liver disease. We have alcohol consumption, cigarette smoking, inherited disorders of the liver, wherein we have hereditary hemochromatosis, alpha-1 antitrypsin deficiency, and Wilson's disease, and metabolic syndromes like obesity, diabetes, etc. So what's happening in here? As with all cancer, HCC induced by acquired mutation in oncogenes and tumor suppressor genes. No single sequence of molecular or genetic alteration leads to emergence of HCC. Among the most common are activating mutation in beta-catenin gene. This is present in 40% of the tumors, and mutation in TERT, which is telomerase transcriptase gene, promoter that upregulate telomerase activity, and inactivating mutations in TP53. The latter are strongly associated with exposure to aflatoxin, which appear in many cases to be directly responsible for TP53 mutations. So these three mutations you can remember. First one is the beta catenin, then we have TERT and TP53. HCC often appear to arise from pre-malignant precursor lesions. Hepatic adenoma is they carry beta catenin activating mutations, and some HCC arise in dysplastic nodules also. So we have low grade dysplastic nodules which may or may not undergo transformation to high grade lesions, but they indicate a higher risk for hepatocellular carcinoma. Whereas these high grade dysplastic nodules, they are the most important precursor for HCC in viral hepatitis and alcohol related liver disease. Now, if we talk about the morphology, so HCC may appear grossly as a unifocal, usually large mass, or multifocal, widely distributed nodules of variable size, or a diffusely infiltrative cancer. So it could be unifocal, means a large single mass, or it could be multifocal, means different nodules of variable size, and it could be a diffusely infiltrative cancer, sometimes involving the entire liver. Okay, sometimes HCC arise within dysplastic nodules and eventually overgrowing these precursor lesions. Intrahepatic metastasis by either vascular invasion or direct extension becomes more likely once tumor reach 3 cm in size. These metastases are usually small and they are satellite tumor nodules around a larger primary mass. Okay, so once tumor reaches almost 3 cm, it will metastasize within the liver. Intrahepatic metastasis, it will form small satellite nodules. Vascular invasion is the most likely route for extrahepatic metastasis, especially by the hepatic venous system. Occasionally, long snake-like mass of tumor invade the portal vein, causing portal hypertension or inferior vena cava. In the later instance, the tumor may extend all the way up to the right ventricle. Lymph node metastasis is less common, so you have to remember this, that a hematogenous spread is more common in case of hepatocellular carcinoma, especially through the hepatic venous system. HCC ranges from well differentiated to highly anaplastic lesion. So if we talk about well differentiated, these are composed of cells that resemble normal hepatocytes and grow as thick trabeculae resembling liver cell plates, or in pseudoglandular pattern that recapitulate poorly formed ectatic bile canal. So as in here, this photomicrograph, we can see these are the all malignant hepatocytes. These are not benign. They are growing in distorted versions of normal architecture, and large pseudo-acinar spaces are there, and essentially malformed dilated bile canaliculi is there with thickened hepatocyte trabeculae. Okay, if we talk about this image here, this is autopsy showing a unifocal, as we can see over here, unifocal massive neoplasm replacing most of the right hepatic lobe in a non-cirrhotic liver. Okay, now what are the clinical features? The clinical manifestations are varied and in Western population are often masked by symptoms related to underlying cirrhosis or chronic hepatitis. In areas of high incidence such as tropical Africa, where aflatoxin exposure is common, patients usually have no clinical history of liver disease. In both population, most patients have ill-defined upper abdominal pain will be there, malaise, fatigue, weight loss, and sometimes awareness of an abdominal mass or abdominal fullness. Jaundice, fever, and GI and esophageal varices bleeding are occasional findings. Now, lab studies may provide clues but are rarely conclusive. There will be elevated serum levels of alpha fetoprotein. So, this is an MCQ. This could be asked. There will be elevated serum alpha fetoprotein in cases of hepatocellular carcinoma, but this is neither a sensitive nor a specific marker. Imaging studies such as ultrasonography or CT or MRI, they are better tests for detection of small tumors. Now, as HCC grows and progresses, their increasing arterialization can be identified by imaging studies. The appearance is so characteristic that tissue biopsy may not be necessary. Okay, because when hepatocellular carcinoma will grow and progress, there will be arterialization, means into the artery. The natural history of HCC involves progressive enlargement of the primary mass until it disturbs hepatic function or it metastasizes, most commonly to the lungs. Death is usually due to cachexia or gastrointestinal or esophageal variceal bleeding or liver failure with hepatic coma, or rarely due to rupture of tumor with fetal hemorrhage. The 5-year survival rate is extremely low and majority of the patients die within 2 years of diagnosis. Now, with implementation of screening procedures and advances in the imaging, the detection of HCC less than 2 centimeter has increased in countries where these are available. So, if tumor is diagnosed when it's very small, then it can be surgically removed or ablated, like through embolization, microwave radiation, or freezing. So this will lead to the good outcomes. When relatively small HCC arise in setting of advanced cirrhotic liver transplantation is better option and may be curative. Radiofrequency ablation and chemo are used for local control of unresectable tumors, and other than this, kinase inhibitors like sorafenib can prolong the life of the patient with advanced stage HCC. So this can also be asked. This was all about HCC. We have seen the risk factors, the epidemiology, the morphological changes, and clinical features, along with treatment options available. Thank you